Good afternoon. This is Dr. James Marion broadcasting live on tape from the Susan and Leonard Feinstein Inflammatory Bowel Disease Center and Mount Sinai Hospital in New York City. And today we have a very special and talented guest joining us today. This is Dr. Chris DiMaio. He's an associate professor of medicine here at the Icahn School of Medicine, and he is the director of therapeutic endoscopy here at Mount Sinai Hospital. I could list Chris's interests in therapeutic endoscopy, but I want to summarize to say that when I started here in the mid-90s, therapeutic endoscopy consisted of our trying to do as much as we could with snares, and that was really just about it. Chris comes in and builds this absolutely phenomenal therapeutic endoscopy presence here on campus and has greatly expanded our abilities in IBD and outside of IBD to better treat our patients and help them avoid surgery. Good morning, Chris, or good afternoon.
Good afternoon, Jim. How are you?
I'm well, and welcome. It is such a pleasure to have you join us for this, and I know that you have much to tell us, but I want to just start with the most fundamental question for you, and that is, what is advanced therapeutic endoscopy?
Well, that's a great first question to start with. First of all, let me thank you for having me and hosting this. It's an honor to be part of your program here. And as you know, we all work very closely here in the division and with the IBD Center. So it's great to collaborate in yet another way with educating our viewers out here today. So you kind of hit the nail on the head. Advanced therapeutic endoscopy really involves the use of endoscopic procedures beyond standard diagnostic upper endoscopy and beyond standard diagnostic colonoscopy with removal of, let's say, small polyps. And you hit the nail on the head earlier in that this field really began, the advent of it was based around two things. One was the endoscopic removal of large colon polyps, and the other was performing endoscopic procedures in the bile duct and the pancreas with a procedure called ERCP. And both of those things started back in the 70s. And over about 30 to 40 years after that, there's been an absolute explosion in our capabilities to diagnose and treat very complicated diseases that typically would require surgical intervention.
Right. So this is sort of like basically taking an insider's approach to what had typically been rather violent, brutal, invasive surgery, right?
Somewhat, yes. One of our main goals when we see a patient is to try and come up with a creative way of either making a diagnosis or performing a therapy without the need for surgery.
Right. So give our viewers some examples of some conditions that sort of, you spend a fair amount of your time on.
So broadly speaking, the field, as I said, in its early stages, revolved around diseases of the pancreas and bile ducts. So conditions such as bile duct stones, gallstones, pancreatitis, inflammation of the pancreas. As our capabilities developed, we have the ability to diagnose and stage cancerous and precancerous lesions of the GI tract. Lesions in the esophagus, the stomach, the intestine, and the colon. And in many cases, we're not only able to just diagnose them or stage them, but we may be able to remove them and resect them. Obviously, with all these procedures, there is a risk, or with many of these conditions, there's a risk of gastrointestinal bleeding. So the management of complicated GI bleeding also falls in our realm. And then, as the medicine field and surgical fields have expanded, we're seeing new problems such as development of strictures, maybe after radiation therapy, maybe after an operation, a colon operation, somebody gets an anastomotic stricture or a leak or a fistula. So we're now called upon to help manage some of these unique complications. And we're even expanding our role. There's a whole new field of endoscopic treatment of obesity, primary treatment of obesity, where we have devices and techniques where we can help patients lose weight for patients who may not have traditionally been a surgical candidate or who may not want something as large as a surgical bypass. There's endoscopic ways of dealing with this, and even motility disorders of the esophagus and the stomach, where, again, we can mimic what surgeons do, but in a minimally invasive platform.
So, Chris, when I have a patient with IBD, there are many areas of overlap where I interact either with you or with your colleagues, Dr. Kumta, Dr. Nagula, Dr. Kim. And it's always a joy, one, because I love seeing you guys, and I wish I saw more of you now that we're all sort of Zooming all the time. But what are some of the conditions, if you could go over some of the conditions that are particular to IBD, that our IBD patients may find themselves in your office or in your endoscopy room?
Yeah. So just to also give a plug that we are a team, and we operate in a team-based approach, a multidisciplinary approach. It's rare that we make decisions unilaterally. We always are interacting with our colleagues in GI, in surgery, in radiology, and pathology. So this is truly team-based medicine, and it's really personalized medicine for each patient has an individual specific problem, and they may require different solutions. So I would like to get that out there, that we do operate that way. But when it comes to IBD patients, the thing that comes to mind mostly are diseases of the small intestine and the colon. So as an example, we know that many patients with IBD are at risk for colon cancer, and these cancers may develop as precancerous lesions or dysplasia. The tried and true method of dealing with dysplasia in the colon is to do surgery, often to remove the colon. But now that we're learning more about the natural history, and we have the tools and techniques, we can safely remove these dysplastic lesions in an outpatient setting, a 20 to 30-minute procedure. Patient goes home and, hopefully avoids massive surgery. So that's one real example where advanced endoscopy plays a role. Another example is patients with inflammatory bowel disease typically develop strictures, and these can be in the small intestine or the colon. And they can be very difficult to deal with. They can be, life-altering, very symptomatic. But again, we have minimally invasive ways of going in there and using a balloon to stretch them open. In some cases, we'll leave a temporary stent to sort of just continuously expand that stricture. We can leave that in for several months and then pull it out. And again, with the hope that this relieves their symptoms and perhaps avoid surgery. We do have creative ways of getting down into the small intestine. I'm sure many people are aware of the video capsule, which is a small pill that can be swallowed to visualize the entire small intestine system. But when that first came out, there wasn't a great way to actually access the small bowel or reach those lesions. But now we have a device called the balloon enteroscope, which allows the user to go from the mouth all the way down into the jejunum and the ileum, and either take biopsies of suspicious lesions, deal with GI bleeding. So again, in an IBD world, the small bowel and the colon, there's a lot of applications for us. As I mentioned earlier, with the advent and explosion of surgery, even in the best of surgical hands, there's always going to be, a risk of complications or adverse events, leaking, fistulas, strictures. So again, we're often called on to support our surgical colleagues in managing these. Again, it may be a dilation of a stricture. If somebody has a leak, it may be closing that leak, maybe with a clip, maybe with endoscopic suturing, maybe with a stent. If they have a large collection, an abscess, there are ways that we can go in there and drain these abscesses. And then I think the other area that people probably don't think much about in the IBD population, but there are unique liver and pancreas diseases that IBD can be associated with. So the most common one is primary sclerosing cholangitis, which is an inflammatory condition of the bile ducts, which can lead to blockages and strictures, and actually is a risk factor for cancer. So it's not unusual that we are called upon to evaluate a patient who may have a symptomatic obstruction of the bile duct, perhaps they're jaundice or they're itchy. And we can use our tools not only to just take simple biopsies, we actually have miniature cameras that can go down the main scope up into the bile duct. And it's like doing a colonoscopy within the bile duct. It's really amazing. And we can take very targeted biopsies. We can rule out a cancer or say, this is a benign stricture. We can place stents. And then another, related to one of my interests in pancreatic disease, there's this increasing recognition of a condition called autoimmune pancreatitis, which one of the diagnostic features of a subtype of this condition is having an inflammatory bowel disease. And in my practice, I've seen a number of patients that we've done pancreatic biopsies to diagnose this condition of autoimmune pancreatitis. And in my experience, a lot of these patients sort of have this lingering pancreatitis that doesn't seem to go away with standard therapy. They sort of linger on for weeks and months. And, now we're recognizing this as an entity unique to IBD patients. And so again, we have the capabilities of taking a biopsy and making a diagnosis.
That's fantastic, Chris. I mean, it's really amazing to me how far you've extended the reach of our scopes, doing these really grand procedures in very small spaces. I know whenever I have the opportunity to step into your room and just sort of watch you do your plumbing, it's a sight to be seen, and I really love it. So Chris, we've come a long ways. New tools coming out all the time. A continued push for further innovation. I know that's really our middle name here at Mount Sinai. What's next? What do you see coming up next, particularly in IBD and advanced therapeutics, or in any area of advanced therapeutic endoscopy?
Well, it's interesting. Just, to go back to the original history of this field, it started mostly with ERCP, or endoscopy of the bile duct and pancreas. And around the same time, the development of removal of large colon polyps. Now, in the year 2020, it seems that every month we're having a new device in our hands, a new technique, a new tool that is being developed to creatively deal with these with the vast array of conditions, medical conditions. So I think, again, targeted towards the IBD population, I think our ability to remove precancerous and cancerous lesions safely and effectively will only continue to get better. Right. People are really pushing the bounds and the limits. We're not taking out, polyps that are just the size of your fingernail. We're taking out polyps that, are several centimeters in size, maybe overgoing multiple folds, where I think the average person would look at that and say, wow, that needs to go to surgery. But again, I think the tools and techniques are quickly being developed, that will be a reality, that will be the first line treatment for many patients with these conditions. I think the other area where there's a need for improvement is management of strictures. Mm-hmm. With Crohn's disease, these ileal strictures or colonic strictures can really be a burden on patients' quality of life. They're in and out of the endo unit. They're in and out of the hospital with obstructions. And we know that performing these balloon dilations is really just sort of a temporary relief. It's a Band-Aid. It's not a good long-term solution. But we now have, and it's starting to make their way from Europe, biodegradable stents, mm-hmm. which are designed to be placed in a benign condition, dilate a stricture, and then these biodegradable stents just melt away over the course of weeks and months. And again, it saves the patient from having to undergo another procedure to remove that stent. Similarly, another big issue for IBD patients are fistulas, whether they are primary fistulas due to Crohn's disease or a post-operative complication. And there are many who are developing techniques where we are using incisional therapy. So instead of trying to close the leaking area or the fistulized area, let's help it drain even better. Let's use our endoscopic dissecting tools to sort of make it bigger, let things drain better, and perhaps that'll let these fistulas and these sinus tracts heal. And there's even been some very interesting work, which I think is going to make a comeback, where folks are starting to use endoscopy to inject biologics and immunomodulators directly into areas of strictures and perhaps fistulas to really get a high dosage concentration of the drug in the area where it's needed most. So I think those are very, very exciting possibilities. I will say, and this is literally hot off the presses, and I can't say too much about it, but some of our surgeons are working right now with European groups and the FDA with trying to bring to the field a device which is placed endoscopically immediately after colon surgery, with the idea that it will eliminate the possibility of anastomotic leaks and fistulas. And it has the ability to revolutionize colon cancer or colon surgery and intestinal surgery, because now it gives the patients the opportunity to have a one-step operation, whereas traditionally they may have had a two-step surgery. So these are things that are rapidly coming. I mean, literally, this is something that came through my inbox over the weekend. So it's really amazing how quickly things are going. And then the one other area which may have some role for inflammatory bowel disease patients, but certainly has a broad applicability, is that we'll soon be able to provide endoscopic therapy to cancers. An example is pancreas cancer, a traditionally aggressive, very difficult to treat cancer, often refractory to things like chemotherapy. Many patients aren't surgical candidates, but using our basic endoscopic equipment, basic endoscopic needles, we can guide needles directly into tumors and deliver drugs. We can deliver an ablative energy. And again, use this as part of a team-based approach to augment chemotherapy, or perhaps downstage a patient who may not have been a surgical candidate to now undergo surgery. So we're really just limited by our own creativity, and it's amazing, truly amazing what is going on. It's a minimally invasive revolution that is occurring right before us these days.
Yeah, no, Chris, and it's wonderful to hear that many of these truly vexing problems are, we're all looking at together and sort of bouncing off potential solutions off of one another, and really hoping for some innovation for these tougher problems.
And,
well, listen,
and I think,
Chris.
Sorry, I was just going to say, and I think you hit the nail on the head. Collaboration is the key. I often joke to my patients that I don't know how to spell IBD. So I often cannot comment on what the natural history of their disease is, their Crohn's disease or ulcerative colitis, or, how long will it take for a biologic to kick in? But that's where our daily communication with each other and our respective teams, we work hand in hand in trying to help our patients. And I think it's a very special thing. I think that's what makes Mount Sinai an outstanding institution. And it has this legacy of excellence in the field of gastroenterology. And I am humbled to be a small piece of that. I think, again, we're still going to keep pushing the envelope, and working together is a key part of that.
And I really look forward to that, Chris. And you are no small piece of it. I think I love bouncing ideas off you. And what can I say? You're a pleasure to work with. We meet every day practically in that cauldron of innovation over in the endo unit.
Where I'm heading right after this.
Exactly. I'll see you later today.
I'll see you there later.
So, Chris, I want to thank you again for joining us. And I hope to have you back here at some point soon, again, to talk about whatever you'd like. I always enjoy hearing you think out loud. And so, again, thank you.
Thank you. Have a great day.
Yes, this is Dr. James Marion, once again, with the third Thursday Facebook Live broadcast from the Susan and Leonard Feinstein Inflammatory Bowel Disease Center here in New York City. And I look forward to seeing you again next month.